Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome, everyone. My name is Renee Garrett, and I'm your SpeechTherapyPD.com podcast host for Functional Neuro Rehab for SLPs. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Laura Purcell Verdun is the owner and solo practitioner at Voice Trainer, LLC. She receives an honorarium from SpeechTherapyPD.com for her participation in this podcast. Her non-financial disclosure is that Laura is a member of ASHA CFCC. She is an ASHA representative, CMS, MACRA, episode-based cost measures clinician expert work group, movement disorders, and is a contributor to both the MSA Coalition and Cure PSP. My financial disclosure is that I am a paid employee of a private consulting firm in the Commonwealth of Virginia, and as the host of this podcast, I do receive financial reimbursement from SpeechTherapyPD.com. My non-financial disclosure is that I am the current secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest tonight, Laura Purcell Verdun. She is the owner and solo practitioner of Voice Trainer, LLC, serving metropolitan Washington, D.C. She is a licensed SLP in both Washington, D.C. and Virginia, and a graduate of St. Louis University. She is a lecturer at George Washington University, teaching professional issues, and a visiting lecturer at Hampton University, contributing to voice disorders. She serves on the ASHA CFCC as Vice Chair for SLP and is a member of the ASHA Ad Hoc Committee on Centennial Planning. Laura previously served at ASHA 21 as the Convention Co-Chair for Rising United and on the Board of Directors for Cure PSP, the advocacy organization for persons with atypical Parkinsonism. Hi, Laura. So great to see you.
Hey, Renee. Thank you so much for having me.
Of course. So I had the good fortune of, I've seen Laura speak many times at our state conference, but I had the good fortune of seeing her this year, or 2023 at ASHA, for her talk on Parkinsonism. And she just always brings such a good wealth of information. And on a personal note, because I like to have a personal connection with people that I host on the podcast, because I've had the good fortune of having a lot of prior contact with people that are on the podcast. And so one of the things that I like to say about you is that, when I met you many years ago, you were famous. And I don't say that lightly, because in my world, I was this student, early clinician when we met, and you just have always been someone who's very approachable. You respond to emails for questions and things like that. And I think for me as a younger clinician, I just always found that very helpful, because that's not the case with everyone. And so thank you for that. And thank you for being such a strong advocate for what we're going to talk about tonight, because I think it's really important.
Thank you so much, Renee.
Absolutely. Thank you for being here. So, what are some atypical Parkinson's syndromes? We'll just kind of jump right in.
Sure. So maybe we could start with a little bit about what's different between Parkinson disease and atypical Parkinsonism and why
Sure.
it matters. Many of you may be familiar with Parkinson's disease. It is the number one identifiable movement disorder. Its primary features are bradykinesia, which is slowness of movement, as well as rest tremor and rigidity. Those are the primary features. A secondary feature is responsiveness to levodopa. Levodopa is Sinemet, and people with Parkinson's respond well to that medication long term. Then it turns out that there are these atypical Parkinson's syndromes. So atypical Parkinsonism presents as similar features of Parkinson's disease, but there are some differences. And that's why we're having this conversation tonight, because these differences are really critical to the lives that these people lead moving forward. Persons with Parkinson's disease will lead an essentially normal lifespan. Persons with atypical Parkinsonism, two really important things. One is their symptoms progress much more rapidly. They're much more devastating than Parkinson's disease. And the second is it will cut their life short. These diseases are just incredibly devastating. These people go through a period of time where they're misdiagnosed as Parkinson's disease. It's not that physicians aren't paying attention or doing a bad job. Sometimes it just takes a while for the disorders themselves to be revealed. So atypical Parkinson's syndromes are really placed into two categories. One are tauopathies, TAU, tauopathies. The other are alpha synucleinopathies. Both of these are just accumulations of these misfolded proteins. And it's where these proteins, the locations in the brain where these proteins accumulate, where the pathology develops. So what we find also with the atypical Parkinson's syndromes is the pathology tends to be more widespread, meaning then the features that the clinical features that they present with are also more widespread. So these protein tau, the tauopathies, the most common ones that we see are PSP, which is progressive supranuclear palsy, CBS, which is corticobasal syndrome. Those are the two that I historically throughout my career have seen most often. You'll hear about frontotemporal dementia, which is also a tauopathy, as well as Alzheimer's disease. The other group, the alpha synucleinopathies, and you notice I'm saying those very slowly so I don't stumble, are accumulations of protein alpha synuclein. And these disorders are Parkinson's disease. So Parkinson's is an alpha synucleinopathy, multiple system atrophy, MSA, and DLB, dementia with Lewy body.
Yeah, that's a lot to digest already.
Okay, yeah. We can go back over anything if it was, don't hesitate. Yeah.
Oh, no. I mean, I love to start where you started. And, I'm running through the list of patients in my mind that I've had throughout the years and I know we've had this conversation before about just cases that really stumped me because the research is still, I think it's widespread, right? There's plenty of research out there, but I think the problem is that the atypical Parkinson's syndrome, like you said, is often misdiagnosed or maybe underdiagnosed because the presentation doesn't always come with all these features that the research has revealed, if that makes sense.
Absolutely. And it's really problematic because then the patients and the families are frustrated. One of the things that often reveals that something is not Parkinson's disease is that they don't respond to Sinemet. That's probably one of the earlier signs that something's not right. And so if somebody's referred to you for speech or voice or swallowing problems and they're not responding to their Sinemet, that should be a red flag. You could think, well, shouldn't it be a red flag for the neurologist too? But not all of these patients are seeing neurologists. Not all of them are seeing movement disorder specialists. I found out from my work on the MACRA, you were referring to the CMS MACRA project that's ongoing. It's about establishing pricing group pricing for movement disorder conditions such as Parkinson's disease. And there's a large percentage of people who have Parkinson's disease who never see a neurologist. They're actually managed by their general practitioner. That was actually shocking to me. And we're not talking like 5 or 10%. It was like at least 40% of people. It could have been up to like 50 or 60, but I'll stick with 40% because I don't remember exactly. But it's a large percentage of people who don't ever get to specialists. This, gets into all sorts of issues about health equity and whatnot, which isn't the conversation for tonight, but this is the conversation for tonight. The reason we're talking about this, one is I think it's incredibly interesting. The second is I have worked with persons with atypical Parkinsonism my entire career. So I started my clinical fellowship in 91 at Johns Hopkins and had the tremendous pleasure to work with the movement disorder team there, which is where I first learned about atypical Parkinson syndromes. But many of the issues we were dealing with back then, expediting diagnosis, that's still a major issue today. And it's a problem because then they don't get the services that they need. They're not referred on to speech pathologists, for example, in a timely manner. They miss out on opportunities to participate in clinical trials or other medications because the diseases, just to follow up on something you just said, the diseases progress so rapidly that it's hard to get them into clinical trials, either because they've just advanced so much or the disease progresses so rapidly, it's hard to have a clinical trial to offer them. So there are a lot of challenges in these populations for sure. But my intent with accepting your invitation for tonight and our great conversation is really just to raise awareness, is to get clinicians, not to be experts, but just to increase their awareness and to start to question the neurologists, the general practitioners, the movement disorder specialists. Nobody knows everything. And you're a very important, integral part of this team in managing these patients.
Yeah, and I think what I've seen in the past is that at least if I'm not in a small rural area, the hospital I served was, but in large, I'm in a place where we have about 7, 8 cities with about a population of around 2 million people. And so the fact that we have folks waiting 6, 8, 9, 10 months to see a neurologist after their initial referral is insane. Because again, that is a 6 to 10 months for people that have something other than a regular PD is just crazy, because you're, like you mentioned, missing out on the opportunity to get speech services involved, to get PT involved, to get OT involved, and any other integral members of the rehab team, because there's roadblocks. Yeah, I'm with you. There's a whole other conversation about that.
These people are desperate. I mean, we all have, whether it's people with atypical Parkinsonism or something, but these people are desperate for support and they're desperate for information. And we serve a really important role in that regard.
Yeah. And just backing up for a second, you mentioned the poor response or no response to Cinemet. What is something else that would be a characteristic of atypical Parkinsonism?
So there's a few things. That's actually a really important question. When is it likely not Parkinson's disease? So it's not like it's going to be Parkinson's disease or motor neuron disease. We're not taking that kind of leap. Those are much easier to distinguish. We're talking about when is it Parkinson's disease or potentially atypical Parkinsonism. So we're also not looking necessarily to say, oh, it's PSP or MSA or CBS. We're not looking for that. We're just looking for initially, this doesn't feel like, this doesn't sound like, this doesn't look like Parkinson's disease. So we talked about not responding to Cinemet or a very limited response and then it easily waning off. So that would be one of the early red flags. The other red flags, particularly relevant to our conversation, are early onset of dysphagia. So early chewing, eating, swallowing difficulties, may or may not be aspirating, but definitely early onset swallowing problems, and they may not have an awareness of it. They may be clinically apparent, but the nature of the disorders, there may be a lack of awareness in that regard. Early falls can be a sign that this is atypical Parkinsonism and not Parkinson's disease. Instability, which is the falls, upper motor neuron findings, pseudobulbar palsy, like emotional lability, quick to tear up, quick to laugh when it's not appropriate. That's an early sign. Rapid progression, things just changing. In Parkinson's disease, for the most part, things go along pretty slowly, but these change rapidly. And then aside from early dysphagia, and I can't reinforce this enough, change in speech, particularly dysarthria that's not hypokinetic. So hypokinetic is the primary feature of Parkinson's disease. If you see hypokinetic in combination with something else or just something else, so if it's an ataxic dysarthria, that's not going to be Parkinson's. That's more likely to be an MSA feature in one of there are definitely subsets of within these individual disorders as well, but you're listening to their speech patterns. And this is really an important point where you can contribute and just discern and describe. You're not making the diagnosis. No, I think this is corticobasal syndrome because they have indications of apraxia, not versus Parkinson's disease. You would not do that, but you would definitely describe what are the motor speech features. Your oral motor exam and your motor speech exam are particularly critical and informative of what you can provide guidance to the families, but also to the neurologists. I have somebody I've seen recently whose features have progressed rapidly, so they're not consistent with Parkinson's disease, but it's really sort of a toss-up in the moment between MSA Parkinsonism and PSP Parkinsonism. And in the big scheme of things, it doesn't really matter because we're addressing the speech and the voice and the swallowing issues all at the same time. But it is important to distinguish that it's definitely not Parkinson's disease.
Yeah, and one of the questions, so someone asked in the chat box, can you repeat the diseases from the tau
Absolutely.
versus the alpha?
You got it. Okay, so you have the tauopathies, TAU opathy. So those are the misfolded protein tau. Those disorders are PSP, which is progressive, supra, not super, supra, SUPRA, nuclear palsy, CBS, which is corticobasal syndrome, FTDP, frontotemporal dementia with Parkinsonism, and then Alzheimer's disease. Secondly are the alpha-synucleinopathies. Alpha is in like alpha, and synuclein, SYNUCLEIN, synucleinopathy. And there are three primary ones: Parkinson's disease, MSA, which is multiple system atrophy, and DLB, dementia with Lewy bodies. And then within each of those, there are common phenotypes. And I can go into those just to name them if you like, or we can come back to that later. I could put those in the chat too. Would that be helpful or no?
That's what I'm doing right now.
Oh, thanks.
I'm doing the quick and dirty version.
Oh, yeah, great. No, that's good. Yeah. Thank you.
Yeah, and I didn't put all of the acronyms, or the abbreviations, but
that's what those are. Yeah.
And then for kind of going back to one of the things that you mentioned, and this is one of the things that initially you talked about it, probably the first or second talk that I ever went to, that fascinated me. And it's about the falls. And it's always been something I shared with my students, was about the direction of the fall that was different from a typical fall. And I know that sounds crazy because we're not physical therapists, but again, when you're looking at features, it's something that I started asking my patients early on was, are you falling forward or are you falling backward? And so is there still a stigma with that, or a research-based backing to that difference in the type of fall and the disorder link?
Yeah. You bring up a really good point. You bring up really two good points. I'll get to the specific fall direction in a second, but it is worth learning about and studying about these disorders more. And you could say, I'm doing a speech language assessment. Why am I asking about falls? Or I'm evaluating their swallowing. Why am I asking about falls? But as soon as there's any question in your mind, they don't sound like a typical Parkinson patient. Then you need to be thinking of some of these other questions, and they take extra moments, but it's just about documenting and just trying to get an understanding of the big picture. So, two things specifically about your question. Persons with PSP will have retrocollis. So they will, their head and neck will start to move backwards, usually related to dystonia, but not necessarily always. Persons with MSA will have anterocollis. So they'll be like this, their head and neck is forward. Sometimes these people may or may not get Botox injections in the neck for the dystonia aspect of that. So following up with what Renee said, then persons with PSP have more of a tendency to fall backward. And so that's really not common that people fall in that direction. And so it's worth asking, what direction are you falling? And that in of itself is not specific criteria. Early falls are a criteria. The direction is not necessarily specified. There are criteria for each of these disorders that are published, but the criteria are evolving. Like it seems like every 2 to 5, maybe, definitely within 10 years, but every 2 to 5 years, the neurologists and neuroscientists and neuropathologists are working to refine the criteria, just again, so that people get a diagnosis, an accurate diagnosis sooner rather than later. And the second is so they can participate in studies. And third is also so that the data is meaningful. Whatever research comes out, that we know, one, they're not, I was going to say polluting, that didn't sound so good, but the Parkinson research, but also they need to be able to have their own research and so that they get their own medicines and neuroprotective agents and therapies and things like that.
Yeah, and there is a couple of questions, but I do have a sort of a segue to the enterocollis and the it left me retrocollis.
Uh-huh.
In regards to swallowing, because we know that forward head position and that retrograde head position may be advantageous to swallowing, because just like when we do instrumental exams, I can't tell you if I could retire tomorrow if I heard, but a chin tuck is best from another staff. Yes, everyone should tuck their chin. And I'm like, holy moly. But I think that's a good point to talk about dysphagia and how those head postures can be impactful for swallowing. And again, like you mentioned, it doesn't always have to equal aspiration, but it can equal residue. It can equal prevalence of things like GERD, which we know is pretty typical in a lot of our Parkinson syndrome patients. And then, if you've got a forward or backward head position, then we know that can also be impactful. So is there anything, that's a completely off cuff?
No, a couple of things. So the persons, who have the anterocollis where they're leaning forward, which is, again, very likely MSA, not always, but very likely MSA. So again, it's more likely a feature of atypical Parkinsonism versus Parkinson's for sure. It's not necessarily diagnostic solely of MSA, but not only is their head forward, but your head is heavy. Like not yours, Renee, but everybody's heads are heavy. And so if you just were to sit there, and you can all just do this with me tonight, if you all sit there, just let your head hang, it really starts to pull you forward. And so that becomes problematic with feeding and just keeping things in the mouth. Like even if you were if you were sitting there with your head down, just trying to chomp on peanuts or something that has a lot of texture and crumbles, like you're bound to lose some of it because it's peanuts and your swallowing is otherwise intact. And so you add a neurodegenerative disease on top of it, it just gets really complicated in that regard. But People who are in this position, like you said, are more likely to do better from a swallowing standpoint than people who are in this position. So people who have anterocollis, sometimes you'll see them in collars, like soft collars, just to give them a little more head and neck support. The one drawback from that is that it provides support and actually then may create weakness because they're just not doing the work to hold themselves up. So there's a balance there. The retroflexion is definitely more problematic, as you would expect, just because of trying to manage the bolus in the oral cavity, no matter what the consistency is. So this brings up another issue, which is not that you asked, but I think it's a good extension of that, is how do you do instrumental exams on this population? And I reinforce with patients a couple of things all the time, that the instrumental exam, particularly with these people, needs to be as representative of their home environment as possible. Number one. Number two, because many times in a controlled environment, their swallowing will look fine. They decompensate when they do things the way they normally do things at home. So for example, people with PSP have disinhibition. It's a nature of that disorder. They're disinhibited. And so they tend to chug a lug and be mouth stuffers. And they don't know this. Like they're not usually aware of it. The family may be aware, but the person with PSP is usually not. So you want to see that. If you do all of your controlled boluses during video fluoroscopy, like they may just be fine. It's when when their behaviors reveal themselves is really when there's a problem. I also do encourage video fluoroscopy over fees for these people. And the reason is predominantly because of maybe movements, but also positioning. It's really hard to get a controlled, successful fees examination just because of the positions that they're in. And so I do encourage video fluoroscopy because I think it's just easier to control the environment, or I shouldn't say control. It's easier to manage the environment, and I think they have more freedom to do whatever they need to do.
Yeah, no, I think that's good because being someone who's performed both of those exams, definitely had patients who came in who were in more of a retrocollis position. And it was really difficult because when you lean your head back, your nasopharynx narrow, and it's really hard to get the scope out, like just jabbing someone. And I don't, I'm not a fan of the pain. I'm not going to jab you with my.
Thank you. Thank you for not doing that. It's really a challenge. And then there's so many contributing factors to their dysphagia. Video fluoroscopy is really the only way to get the big picture. I mean, that's my professional opinion. So.
Yeah. And I've definitely scoped people who were in interesting positions and things like that. But it is a challenge because the one thing we don't want to do is cause discomfort. It's already going to be for some people are more discomforting than others, or experience more discomfort than others. But if your head positioning is such that again, I'm with you. I'm about the naturalistic setting. I have done controlled boluses, and I've done where I'm like, okay, we know this person is someone who's chug-a-lug, and I want to see what happens when they chug-a-lug.
Yes, because you have to.
Sometimes they chug-a-lug and they're fine, and sometimes they chug-a-lug and you're like, oh my God.
I'll have them bring in items, either like whatever cup or glass they're usually drinking from, or like special food items. So you can go through your MBS-IMP protocol, whatever, and then do something else. One of the first patients I ever saw when I was at Hopkins had PSP. Actually, two patients. One's complaint was with shrimp and peanuts. Okay, well, there's not shrimp and peanuts in the hospital that I could acquire. So I'm like, bring it with you. The other patient also had PSP and just wanted to drink coffee and his coffee cake. Like he was willing to do, he didn't care about anything else. He just wanted coffee and coffee cake. And so it was like, bring your coffee and your coffee cake again. And, you just try to meet them where they are. And I get their challenges to video fluoroscopic swallowing studies and how things are run within institutions, but any opportunity to get a better handle on what's going on. There are no features that you will observe in video fluoroscopy. There are no features you will observe that will dictate this is Parkinson's over atypical Parkinsonism. There's also no features that will distinguish amongst the atypical Parkinson syndromes. This is all just about getting a better handle on their swallowing impairment.
Yeah, no, I think that's a great point. We do have a couple of questions. Can someone experience a disease from the tau and alpha simultaneously, such as frontotemporal and LBD together?
So I guess anything is possible. I'm going to also include the second part of that question, or are these diseases only confirmed post-mortem? So there is a thought that these disorders, these atypical Parkinson syndromes, exist across a continuum. There are there are many times where it is very difficult, even particularly expert movement disorder specialists aren't able to distinguish between somebody with cortical basal syndrome and progressive supranuclear palsy during life. And it's not, again, that they're not a good physician. Like they're amazing clinicians out there. It's just the disease hasn't revealed itself. And so, yes, all of these disorders will be confirmed post-mortem. Sometimes it will conflict with what the diagnosis was during their life. They went all along and thought they had PSP, and postmortem revealed that it was CBD. And obviously that's what reveals the truth. The goal is to try to again, they're always trying to tease out what are the clinical features that's most relevant, what diagnostic testing is most necessary and most revealing of the diagnosis. But the criteria are evolving all the time. And so yes, definitive diagnosis comes from post-mortem exams. There are brain banks around the country who are particularly interested in these people and what they're struggling with. For example, Cure PSP, which is curepsp.org, is the advocacy organization for persons with atypical Parkinsonism. And then the MSA Coalition, their specific focuses on MSA. But I know Cure PSP has information on their site on brain banking and brain donations.
And the other question, well, and I kind of a side note while I get the other question pulled up. And you know this, my mother-in-law was diagnosed with Alzheimer's, and obviously now that she's passed, we're not doing any kind of testing or anything like that, but there's the other comorbidities she had really lent themselves more to a vascular dementia, just based on the congestive heart failure and the diabetes. It really, and she really did sort of, in my professional opinion, lean more towards that versus a true Alzheimer's. But between this time last year and now, over the course of time, things developed quickly and differently. And it was more about the physical health and her physical capabilities than it was about her cognitive function.
Interesting.
I feel like the health conditions and things like that were far more impactful than the cognition prior to her passing away. So I think it's important to note that, like you said, I worked with some really great movement disorder specialists and some neurologists who maybe that wasn't their forte, but they, and I think that's a good point too, is that a lot of people aren't aware that neurologists have specialties. They have specialties for movement disorders. Maybe they're the MS specialist. They're the person who deals primarily with some other disorders. And I think that's a great point that you make, which it wasn't really a big point as far as a highlight of what we're talking about tonight, but it's an important point because when we're looking at referrals for patients who come to us and say, this is this host of symptoms and this is what you're seeing in your assessment, then you can, again, document, describe what you're seeing, and then you can maybe say, this person is the movement disorder specialist. This may be a person that you want to go see as your neurologist. We don't have a ton of them in our area.
There
which is great.
Just as a side comment that I just put in the chat, there is the International Parkinson and Movement Disorder Society. So you can look for members of that association, whether it's a speech pathologist like myself or neurologists. The MSA Coalition has recently identified MSA. I don't remember what they call it, but it could be MSA Centers of Excellence or something around the country. And Cure's PSP also has the same thing, Cure PSP Centers of Excellence. So you can look at both of their websites, and they have those types of resources. Getting back to the health equity remark earlier, is not everybody has access to this. But the issue is for you at least to share the information, share the websites. There's a lot of information available for patients and caregivers on those websites, and encourage them, even to get a second opinion in their own community. So it may not be a movement disorder specialist. You're in Southwest Virginia, that may not happen. Like, there are some incredibly remote, we're both in Virginia, but there are some incredibly remote areas of Virginia. So I realize access is a real concern, but it's about trying to provide people as best of resources as possible, and also continuing to ask questions. This doesn't make sense to me, and reaching out to the referral source and explaining to them, what are you observing, what are you hearing, so that they understand and can hear you. I don't need to tell Renee this, or I suspect anybody on this Zoom today, is that, we spend a lot of time with these patients. We spend more time with them than the physicians do. So we hear things, either things they're telling us, or just hear them as they tell you their story. And as you go through your oromotor and your motor speech exam, you spend more time and you start to hear things, and you're looking for patterns, and it starts to raise questions. It's your responsibility then to continue to ask questions and follow up with the referral source.
Yeah, that's a great point. And so this is a really good question. How does essential tremor compare to these disorders?
So essential tremor is shaking, okay? Periodic shaking. You may see it in the hands, you may see it in the head. You can get tremor in the voice. Which is interesting, because most people who have Parkinson's disease or atypical Parkinson's disease don't get vocal tremor. Vocal tremor seems to occur independent of those. The second thing is, they don't often present or have tremor. Parkinson's disease will, but these persons won't necessarily, or maybe not as a presenting symptom. But they're having Parkinsonian tremor, not tremor in isolation. So essential tremor occurs unrelated to any of the other presenting symptoms.
So that makes me have a question.
Yeah.
So can that be a precursor to an atypical Parkinson or a Parkinson's syndrome?
I think that does not, you can't say no ever. But I think that tends to not occur so often, that's less likely to be a presenting feature. So for example, someone with PSP may look Parkinsonian in that they're maybe moving a little bit slow. So they may have the bradykinesia component, which is slowness of movement. They may have that component of Parkinsonism, but then they start to present with oculomotor changes, which is what the supranuclear comes from. That's reference to supranuclear gaze palsy. So they have trouble raising their eyeballs up and down. So they may have the slowness of movement of Parkinsonism, but then they develop other features, such as the supranuclear gaze palsy, the instability, the backward falls, and then they often have the cognitive changes, the executive function changes we talked about. We talked about the disinhibition. So they're not likely to present with tremor. They're likely to present with these other features. Does that make sense?
Okay. Oh yeah, no, my brain is working now.
Yeah.
At this later hour, my brain all of a sudden has decided it wants to be smart.
Yeah. Yay. Yeah.
Well,
okay, we can go all night. Yeah.
And I think you kind of touched on this already. Why is, what's the importance in distinguishing the how is that impactful?
So the reason it's important to distinguish, this is actually maybe the most important question of the night. The reason it's important to distinguish between idiopathic Parkinson's disease, which you're most familiar with and most likely to come across, and atypical Parkinsonism is because these people will die from their disease. They will die from complications of the disease, most likely aspiration pneumonia. They will die within anywhere from 3 to 5 to 7 years of onset of symptoms. Not time of diagnosis, because years will have gone by the time of their diagnosis. But they will more than likely die in less than 10 years. Those were intentional numbers that I used. And so it is critical that we intervene as soon as possible to optimize communication, to optimize swallowing, to have difficult conversations about assistive and augmentative communication, difficult conversations about nutrition and feeding tubes. For persons with MSA, conversations about tracheostomy. Persons with MSA specifically are vulnerable to airway compromise because they develop impaired vocal fold motion. It's not entirely clear whether it's dystonia, whether it's actually paralysis, but persons with MSA, 30+% of those will develop airway compromise related to impaired motion of the vocal folds. So they are looking at tracheotomy, whereas PSP, CBS, Parkinson's disease, they are not, okay? And so people need to be informed and educated as to the anticipated course. I don't mean you see them their first day, they have a diagnosis of PSP and you're going to unload all of this on them. I don't mean that, but the issue is they, and I talk to other clinicians about this, like we're talking tonight. I talk to patients about this. So I do family and caregiver presentations, and obviously I work with families and caregivers. And I say that, at some point, sooner rather than later, there needs to be a conversation and you need to have made some decisions. Now, you may decide not to make a decision, and that's still a decision, but you need to be informed and make a decision as to how you want to proceed. You need to communicate that with your family. You need to communicate with your physician so that there's no miscommunication. And those conversations should be repeated as time progresses, because, we're all here doing reasonably well, okay? But at some point, things are going to change, and things are going to change fairly rapidly for these people. There is nothing that can prepare them for this. You can have, they can talk to other families, and, and Renee can even speak to this, like she was sharing her own personal experience. You don't know what you're headed for until you're in the thick of it. And so trying to prepare, these people really do need information, education, support, but they need to make decisions sooner rather than later, because there will be a point when they're not able to make decisions for themselves, and decisions will be made for them, and it may not be what they wanted. Whether it's resuscitation, whether it's feeding tube placement, whatever it is. And I'm not coming from a place of judgment at all. I am solely coming up from a place of advocacy and information, so they can make whatever decision works for them, their family, their religion, their culture, whatever it is, but at least it's been communicated. I think that's so important.
I do too, and I think that there's such a big movement right now in discussion for shared decision and informed decisions, and I think that's a big piece of it, because it's about the education and the options, and the options I think are something that are important, and definitely something that I've changed throughout my practice, because when I was a brand new clinician, it was like, oh, I'm going to help you make this decision because I know all the things. I just graduated and I'm real smart and stuff. But your life experience and your patient experience definitely, I think, changes you and how you're informing your patients, because you're coming from a place of, okay, I've seen XYZ. This patient really had a hard time, and this patient was very straightforward in the decision-making process. And then sometimes you have 7 children or whatever, 7 siblings. You have all these pieces that want to have a say in this final decision-making process when the patient's been clear all along.
Mhm.
And flipping that, sometimes the patients change their mind when they're in the thick of
Yes.
it, when they get to the point where things are really tough and challenging, and they're like, you know what, I just want to have a meatball sub or whatever it is, and if I choke, I choke. And I've heard that many times. If it, I don't want to use an artificial talking device. That was one I heard not too long ago. I don't want to use an artificial talking device. And we did a whole, spiel about that in the education. And we talked about voice banking. We talked about, and this was someone with frontotemporal dementia. Um, we talked about voice banking. We talked about scripting and priority vocabulary for the device. And at the end, he said, I don't want that. And that was really hard for me because I was like, oh gosh, but you could still communicate if you just had the device. But it wasn't, and this was someone who was very highly educated. It wasn't, not that that is the be all end all, because it just, he had spent so much time doing his own research and really thoroughly understanding what it is he was not only facing as a disease, but his communication options. And at the end, he said, I would rather not have a machine talking for me, is what he said. And I was like, but at the same time, it was my job to respect his decision,
Yeah.
know
Yeah.
that I had informed him. He had done his own research. His wife was a huge advocate. She'd done a ton of research as well. And as much as I really wanted to get him this dang device, he said no. And I had to respect that. And so when we're looking at the shared decision making, we have to take ourselves out
Yes.
of the picture because it's not our choice. And I don't come from that now as more of a like I know more than you kind of thing. It's more like, oh, I want to help you. Oh, I want to fix this. I still have to fix it. Like I want to fix you. I want to help you. I want to give you all the things. But sometimes people say no, thank you. And we have to be okay with that.
It's exactly right. It's exactly right. Because you're not trying to influence them. That's not your role. Your role is just to inform and make sure they know, just lay out all the options. But you made a really good point about people will change their mind. It'll happen, which is again why whether you revisit the conversation with them, whether they as a family revisit the conversation, and these are really, really hard times, really incredibly challenging times. But it's about giving them the opportunity for choice when they have the ability to do so before it's taken from them. So to me, I feel professionally and personally that that's incredibly important.
Yeah, I do too. And that kind of leads me to what we as SLPs can do for people with atypical Parkinsonisms.
This is actually another really important question because you would think, and this was really the sort of the crux of the additional crux of our conversation at ASHA in Boston in 23 was take these people on your caseload. They're like any other person on your caseload. Yes, you want to be informed about the disorders. What's the difference? If you have people on your caseload that have Parkinson's disease, these people are similar enough. The challenge is that things are changing rapidly. So you're still working on things like comprehensibility. What are their communication options moving forward? Everything you just alluded to with your frontotemporal dementia, a person with FTD, it's the same sort of thing. And the same thing with swallowing. You're still looking for what can you do to minimize the risk of aspiration, optimize nutrition, enhance, efficiency and safety of swallowing. One thing that came out of our conversation at ASHA, which is also really important, is addressing cough. And cough, you would be doing that with any other patient and use of respiratory trainers for cough treatment, not only for coughing to keep the lungs clear, to keep the vocal folds active. It turns out the cough research is supportive of improvement in swallowing. The majority of the work in this population has been done specifically looking at persons with MSA, but it has implications for PSP in particular, maybe CBD a little bit, CBS a little bit less, but the same things you're looking at in all the other patients who are in your outpatient clinics, or they happen to be admitted in regards to communication, cognition. These people do have, some of them have cognitive and language changes, and voice and swallowing. It's the same thing you're already trained to do and already aware of. Things are just moving faster, but take these people on, and then ask questions of them, their family members. You're always welcome to reach out to me. But there are resources that are available. There is a publication on the Cure PSP website, I think it's every social worker, PT, OT, and speech pathologist needs to know. It's a workbook. I wrote the speech section, and it's all, you'll look at it and go, well, this is fairly foundational, fairly rudimentary, because these are the things you already know. And it's with attention to, some things like, we were talking about the anterocallus and the retrocallus, so, what to look for there. But you're approaching them like you would any other patient. You don't have to have expertise. In fact, if you wait to get expertise and to see a whole load of these people, it's just not going to happen because there just aren't enough of them out there. And so as one comes in your door, then you're already more expert with that person than with the next person that comes through the door. So please welcome them into your clinics.
Yeah, that's funny because oh gosh, again, as a new baby clinician back in 2010, I was already seeing people with Parkinson's. And one of my I've talked to you about this before. One of my dear one of my favorite patients had PSP. And this was back in like 2011, I think. And I was definitely not, well, I'm still not an expert, but I wasn't an expert. But I learned so much, and I did the work, and I did the research, and I tried to give them, the most information that I had in the education piece. And I didn't actually get any kind of Parkinson's certification until, what year are we in? 2022. So I had been practicing for quite some time before I went out and did any kind of certification, and that was mostly for marketing for our outpatient clinic.
Sure.
It wasn't sure. Yeah, I mean, it's a great organization, and I'm not a paid spokesperson, but the Parkinson's Voice Project for me gave me some really good foundational information, and they're doing some great work and some great research. But
Could
yeah,
I interject
I'm with
just
you.
1 second? That's really important about that. So the Parkinson Voice Project and Lee Silverman Voice Treatment, LSVT. So there has been limited studies using those programs for this population. And any of the studies that have been done are really small in numbers. This would be another indicator that this is a person who has atypical Parkinsonism and not Parkinson's disease, is really how they respond to those treatment protocols. Because people with Parkinson's, as we know, respond very well. And people with atypical Parkinsonism may not, or they really have to labor through the process, or they don't have the carryover that people with Parkinson's disease. So if you have a person you're pursuing those protocols with, and it's just not working out, though everybody's doing the best they can, that's, definitely a consideration.
Yeah, and that may be the one that you want to try to get a referral for, and maybe see what else is going on. And again, that happened to me back in the fall. I had someone without a diagnosis, but the features of everything they came in with were so very much like a progressive neurological disease that wasn't, because she's a retired physician's wife, and she didn't want, she's in her 80s, she's decided she didn't want to know. She
Yeah.
wanted to do the treatment. She wanted
Yeah.
to see if it would help her be understandable on the phone to her
Sure.
kids who live out of state. She wanted to see if when she went to dinner with her friends that her conversational speech was more easily understood, was more intelligible, was more her vocal intensity was better so that she could speak to her group of 5 or 6 lady friends that she went to dinner with without having to shout and then become hoarse.
Sure.
All of those things. And so we kind of did, um, not a straight on protocol, but some of the features of the protocol. And we did some EMST training with her because she was having a lot of trouble with breath support. And I kept saying, the neurologist might be able to give you a piece of the puzzle you're missing. And she finally just said, I don't think I want to know. I think I want to do this and then I'll practice at home. And, I'll come to 5 sessions.
Yeah.
Initially, it was 5
Yeah.
sessions.
Yeah.
I don't 5. We wound up doing, I think, 12 total. And she said, I feel this was her. I feel like it's helping. I feel like I've gotten better and I'm going to keep practicing and I'll come back in a few months. And then she said,
Yeah.
but again, that was shared decision making at its finest because I said,
Completely. It's a choice. Yes,
these are the
absolutely.
things that I need you to know in order for you to make the
Yeah.
best decision for
Yeah.
you. Because
Yeah.
ultimately it's for that patient.
Yeah.
So yeah, I think we definitely see just a mixed bag. And like you mentioned several times, she definitely didn't seem like it was a strictly, I don't want to say straightforward because Parkinson's disease in and of itself is not always so straightforward
Mhm.
either. Definitely presented more like something atypical versus an idiopathic syndrome.
Sure. I followed up in the chat. Somebody asked about MRIs. So MRIs are not used solely to identify. They're not able to do that. They're doing other PET scans and whatnot. But even the imaging is not is not decisive as far as making diagnosis. I included in the chat the diagnostic criteria for the MDS means the Movement Disorder Society, which is the international Parkinson's organization I mentioned earlier. They changed names a few years ago, but the Movement Disorder Society diagnostic criteria for Parkinson's disease in 2015. The MDS criteria for PSP, most current, is in 2017. CBS, the diagnostic criteria hasn't changed since 2013. CBS is the least common of all of these by far. And then the Movement Disorder Society criteria for multiple system atrophy was just updated last 2 years ago. Also, unfortunately, Dr. Wenning is a neurologist out of Germany who's been at the forefront of MSA research. Just passed away, I saw like a week ago, which is a huge loss. He was late 50s and has just really been at the forefront of MSA research.
Well, and just to clarify for people maybe who are more seasoned clinicians, CBS and the former CBD, so corticobascular.
Oh, yes. So thank you. So CBS and
same?
CBD, cortical basal syndrome, cortical basal degeneration. So CBS is the clinical diagnosis. CBD is the pathologic diagnosis. So you'll see, and they'll still be used interchangeably these days. But you'll see, symptoms consistent with cortical basal syndrome, but then on their post-mortem, it'll say cortical basal degeneration. Yeah.
Okay. Thank
Yeah.
you.
Yeah.
Yeah.
They all at some point had other names. So when I started out, yes, it was cerebellar atrophy. There were just all spinocerebellar degeneration. There were other names. And so these have, again, developed over the years and have really solidified into these disorders. You read these papers, and even as my conversation tonight, it sounds like they are distinct disorders. But as I responded to the question earlier, it is hard to distinguish these clinically, and even sometimes, at postmortem, do they exist? do PSP and CBS really exist across the continuum? Are they really separate entities or not? And they're trying to pigeonhole them into separate entities, but it's not always so clear cut. What we're looking for tonight is you either have Parkinson's disease or you don't. Okay.
Yeah.
And if you don't, then this is really what you're looking for. Yeah.
Yeah. Well, Laura, thank you so much for joining us tonight. I appreciate you and all the work that you've done and your willingness to share. I always, and I probably say this a lot, but I always get a lot from your talks, and that's very true. Like I've watched you in various state conferences and now at ASHA, and there's always a takeaway for me as a clinician, and I think that's really important to note that your work has been very meaningful. So I so appreciate you coming on as a guest, and I'm looking forward to the future and the research that comes out. Certainly the contributions that you continue to make. Is there anything else that you kind of want to leave us with tonight? Any research?
Yes. So on the speech pathology front, two clinicians who I had the tremendous honor to work with for ASHA 23 are Heather Clark out of the Mayo Clinic in Minnesota. Does amazing work, and she's doing a lot of her work is on motor speech and cognitive linguistic changes in these disorders, as well as Michelle Trocha. Michelle Trocha is up at Columbia in New York, and she's doing tremendous work on swallowing and cough. And so they are great people to really, I'm putting their names into the chat. They are doing amazing work. And so those are the two I would definitely read up on and continue to follow moving forward.
Well, thank you so very much. Just want to check the chat box one more time. I think that might be you that typed that in. Yeah. And someone said, please come back on for treatments. This is awesome. All right.
Thank you, Renee. Thanks, everybody. Spread the word.
Right?
Yeah.
And thank you. And we look forward to seeing you again.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.